Dr. Chad Deal graduated from the University of Arkansas School of Medicine. After completing his internal medicine training at Boston City Hospital, he completed his rheumatology fellowship at Boston University. In 1999, he established the Center for Osteoporosis and Metabolic Bone Diseases at the Cleveland Clinic Foundation. Dr. Deal is currently an associate professor of medicine at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University School of Medicine. He is a staff physician at the Cleveland Clinic and head of the section of osteoporosis and metabolic bone disease. Dr. Deal has been an investigator in clinical trials in the treatment of osteoarthritis. He's also been a lead clinical investigator in numerous osteoporosis trials, a lead investigator of trials showing the effect of combination anti-resorptive and anabolic agents for the treatment of osteoporosis, and has authored over 70 publications. He's a member of the committees and served on the board of directors for the American College of Rheumatology, and he's currently associate editor for the medical journal Arthritis and Rheumatology. He's a medical educator at the Cleveland Clinic Lerner School of Medicine, and he's been co-author for the osteoporosis management chapter for the textbook Rheumatology for the last 3 editions. He's also a master of the American College of Rheumatology. So with that, I'd like to welcome Dr. Deal.
First thing I want to do is congratulate Deborah and Denise and the staff. I think to develop an organization from scratch and then 15 years later have, a meeting where you have 200 patients come is an amazing accomplishment. So I'm in awe of that. So I think a round of applause. And, most importantly, this organization has made a difference and will make a difference in the lives of many patients, and now I think will make a difference in physician awareness of this disease that I think is actually much more common than we ever appreciated. The second thing I want to say is I started the day with a little bit of embarrassment because I passed somebody in the hallway and they said, "Hello, Dr. Deal," and she could tell I looked at her quizzically, not knowing who she was, and it turns out it was my patient. Maria, are you here? There's Maria. So apologies, but let's catch up because we missed each other at the last visit because I've been on medical leave for a couple of months, but I'm back and kind of normal now. So the third thing I want to say, I'm not even, I just jotted these notes down as I heard everybody speak, is that Deborah said we really need more doctors to know about this disease, and I can't agree with that more. I think we're making progress. I finished my fellowship in 1982. And between 1982 and 2007, I did not diagnose one patient with HPP. And then in 2007, I saw a patient with poorly healing metatarsal fractures. And I was talking with Gary Gottesman, who you'll hear from later. She had what's called the Mayflower mutation. And in 2007, we had no treatment. But as a metabolic bone disease person, I treated her with a PTH analog, Forteo. And she actually did extremely well. And since that time, there have been numerous case reports of treatment of mild bone disorders and fractures with HPP with PTH analogs up until the time we had Strensiq in 2015, and then our whole world changed in terms of the appropriate treatment or treatment options for this disease. Those are kind of my introductory remarks. So I'm an adult rheumatologist. Dr. Saul is a pediatrician. And since 2019, I've seen and diagnosed probably 20, at least, patients with HPP after not having diagnosed anybody for years and years and years. And I think that's because physicians are realizing it, patients are realizing it, and adult HPP is a real challenge in terms of its clinical presentation, its clinical course, in terms of who to treat, and what the manifestations are, and that's what I'm tasked with talking about today. So I am a speaker and consultant for Alexion. So as you all know, so first of all, how many patients have HPP here? So, okay, that's a lot. I'm always hesitant to talk about manifestations of HPP in front of that many patients with HPP because I know that I am not going to get everything right because this disease is so variable. And so please, during the discussion period, the physician Q&A or afterwards in the breaks, come up and educate me, okay? I learn from you guys. So I see patients with adult HPP who have had chronic pain or fractures for years and years and years and have never been diagnosed. And hopefully that will change now. As you know, HPP has an extremely wide range of clinical manifestations, and it has varying clinical phenotypes, or what we call the observable physical properties of a disease. Many of the clinical symptoms are nonspecific. That's why you've been told, many of you before you were diagnosed, that you had fibromyalgia or something like that, some kind of chronic pain syndrome. And the clinical course after that time is variable, and I'll give you a couple of cases in my experience just to illustrate that. The first one is a young man, 32-year-old white male, and his symptoms were fatigue and muscle pain. When he rated his pain on a scale of 0 to 10, he was a 9. And he particularly had pain in his knees, and the knee pain was so bad he paid for stem cell injections into his knees himself because insurance wasn't going to cover it, and of course that didn't do any good. He had some fractures, but they were probably just fractures that occurred with, trauma. But he had premature tooth loss. And one thing that's really important when I see patients and want to get stringent covered is they have to have symptoms before the age of 18. So we have to diagnose HPP as, perinatal or adolescent HPP. And one of the ways that I get stringent covered is getting that history of premature tooth loss if it's there. And this patient had it. He was a nurse on the wards, and in 2012 his pain was so bad that he couldn't do the job of a nurse. Any nurses here? Few? Standing on your feet all day on the wards is a very strenuous day, especially nowadays when there are lots of 12-hour shifts. But luckily he was able to switch to a desk job as a nurse and continue to work. So at the clinic, everybody does what's called a PROMIS 10 global physical assessment. And this is basically just a patient-reported outcome for how you're doing in terms of activities of daily living. And he was in the second percentile, which means that 98% of patients in our database perform better than him on activities of daily living. So with those symptoms and that kind of life-altering pain, he is a candidate for treatment. He hadn't had lots of fractures. He didn't have a lot of skeletal manifestations. He had this wide spread muscular and bone pain. I call it the pain phenotype, which in my practice is one of the most common presentations. Now, out in this audience, one of the most common presentations may very well be, early fractures and other things. That is not my experience now in evaluating and treating adult HPP patients. His alk phos was low, his B6 was high, as you heard from Dr. Saul, and interestingly, his bone density was normal. In a young man, we don't use T-scores, we use Z-scores, and a Z-score of -1 is considered normal. And it's interesting that many patients with HPP have normal bone density, not low bone density. And I don't understand exactly why that occurs. This is a disease of bone mineralization, of hypomineralization, and you would think that everybody would have a low BMD, but they don't. Dr. Saul talked about genetics, the genetics of it. His mutation analysis was normal. And 10 years ago, I think, when we sent off genetic testing, many times mutation analysis was the only thing that was done. And nowadays, you'll get, in addition to mutations, you'll get what's called gene duplication or gene deletion. And he had a gene deletion that had been described before in patients with HPP. So he had the abnormal genes, he had severe symptoms. Strensic was started February of 2023, and his global physical went from the 2nd to the 53rd percentile. His global mental functioning, he was somewhat depressed because of his condition, went from the 19th to the 73rd percentile, and his fatigue went from the 1st percentile, which means 99% of patients had more energy than he did, to the 58th percentile. Now, I wish that everybody I saw and put on Strensic had this kind of response, but that's not always the case. Some patients don't. As Dr. Saul mentioned, Strensic is a molecule that is specifically manufactured to hone to bone. And we know, as Deborah in her introductory remarks talked about non-bone effects of this disease, that there's a lot of non-bone symptoms in this disease, including muscle, including fatigue. Why do people have this symptomology? That's where we need more information, more research. That's where we need new drugs that have the potential not just to treat the bone, but to treat all the other manifestations of this disease. So in the adult world, when you look at how patients present, you can look at the literature, and there's lots of different approaches. One approach is to look at low alkaline phosphatase in large databases in the electronic medical record. And in these kind of searches, you can find large numbers of patients with low alkaline phosphatase, and many patients are asymptomatic in studies like this. If you look at patients in rheumatology clinics or in endocrinology clinics, or in Europe, as they call it, osteology clinics, those patients are referred, and there's a tremendous referral bias. When they come to a rheumatologist, they're much more likely to have rheumatologic manifestations. When they come to a metabolic bone disease expert, they're much more likely to have low bone mass and fractures. When they come to an endocrinologist, they may be a different type of patient profile. So the adult symptoms are always in studies biased in a way, because there are different referral patterns. Then there's patients' studies that have been published based on, well-diagnosed patients with HPP, like the global registry HPP, and there are over 400 patients in that global registry. And Dr. Dahir, who's at Vanderbilt in Nashville, recently published in Frontiers in Endocrinology data on 370 some odd patients in the global registry, and she divided the patients into a skeletal group, and that was the most common manifestation in the global registry, 300, and then the muscular or pain group, which is what I tend to see a lot of, probably more than the skeletal group nowadays, 73. And the skeletal group had characteristic features of metabolic bone disease like rickets, which is a childhood disease of hypomineralization, often presenting with bowed tibia and bone pain. And in adults, we call that osteomalacia, same thing in adults. Poorly healing fractures, as I mentioned, that was my first case that I saw in 2007. As an adult rheumatologist, I'll see patients with calcific periarthritis. Dr. Saul mentioned that there's a lot of calcium, there's a lot of phosphorus around that is not being utilized for bone, and so there's probably a higher calcium phosphorus product in tissues, including tendons, ligaments, certainly kidneys. You heard about nephrocalcinosis. So calcific periarthritis is occasionally a manifestation of the disease. Pseudogout and chondrocalcinosis. Pseudogout is like gout. That's why it's called pseudogout. It's a crystalline arthritis caused by the shedding of calcium pyrophosphate crystals into joints, which are very inflammatory. As a teacher, somebody who teaches rheumatology fellows, we teach them that the 4 diseases associated with chondrocalcinosis are hyperparathyroidism, we call it the 4 H's, hypomagnesemia, hemochromatosis, and hypophosphatasia. I learned that's a board question. I learned that from the time I was, in my 20s, and yet I never diagnosed a patient with chondrocalcinosis and HPP until 2007. And chondrocalcinosis is calcification in cartilage. That's all it is, and you can see it on the X-ray. I'll show you a picture. Hopefully you'll be able to see it on the screen. The muscular group I've already mentioned: muscular pain, body pain, weakness, fatigue, fibromyalgia. Many patients meet the American College of Rheumatology criteria for fibromyalgia, and then bone pain. Dr. Vega-Menon considered these the manifestations or the musculoskeletal disorders in HPP: poorly healing fractures, rickets in childhood, osteomalacia in adults, chondrocalcinosis, pseudogout, osteoarthropathy, chronic muscle pain, muscle weakness, and fatigue. So what we've already talked about. Okay, now this is a complicated slide, and I'm not going to go through all the details. This is one of those database searches, and I think what I wanted to emphasize in this is that in the Marshfield Clinic in Wisconsin, this is Fergus McKiernan, who's a rheumatologist and retired now, there were 270,000 adults who had at least 2 alkaline phosphatases measured in their electronic medical record. There were 5,190 with 2 values below 40, which is kind of our cut point for HPP. And he even went further, wanting to enrich his population for definite HPP. There were 809 with 2 values less than 30, and never above 30. So when you look at how many, what's the percent of patients in that population who had low alkaline phosphatases, it was about 1 in 1,500, or about 0.06%. That's was a startlingly high incidence of low alkaline phosphatase in the population to me. We had always been taught that HPP occurs in about 1 in 100,000 patients. That's 0.001%. And there are clearly many patients with low alkaline phosphatase who may or may not have symptoms, but who may develop symptoms 10 years, 20 years, or 30 years down the line. And the problem when you identify a 35-year-old patient with low alkaline phosphatase, as Dr. Saul had mentioned, when is the appropriate time to step in? Are you going to wait until they have a femoral shaft fracture or some other serious manifestation? Are you going to treat them early? What's the most appropriate time to intervene, especially when you're talking about a drug that costs $1.5 million a year? So that's a very difficult question to answer, and we need more information. And again, Dr. McKiernan saw what we've already talked about, chondrocalcinosis. Enthesopathies are calcifications of tendons where they join bone. Calcific periarthritis, calcifications in tendons where they join bone or around bone. Shoulder would be the most common. Diffuse idiopathic skeletal hyperostosis, DISH. This is calcification of the anterior longitudinal ligament in the spine, more common in patients with HPP. And various exostoses, bony protuberances, calcific bony protuberances. And I don't know how well you can see this, but the middle x-ray at the top is a knee. So the top is the femur, the bottom is the tibia, and that arrow points to an area of calcification in cartilage. That's chondrocalcinosis. The x-ray right next to it of the knee, that's a lateral view of the knee. You can see the arrow points to a exostosis where the patellar tendon inserts on the tibia. And again, it's probably a result of high calcium phosphorus product in tissue. And I do feel that Strinsic, since it will result in utilization of calcium and phosphorus for what it's supposed to be, for the formation of calcium hydroxyapatite in bone, I do feel that patients will improve in terms of these types of manifestations. When a patient comes to me with this disease and they have fractures, I usually tell them I'm almost sure that I can really make a difference, if that's their major manifestation, with Strinsic, because it will heal fractures. The other manifestations like muscle pain and bone pain and widespread pain, I'm less confident that patients will respond in the same way. Another example, this is HPP in a rheumatology unit. This particular rheumatology unit saw 9,522 patients, and when they went back, there were 524 of those patients, like more than 5%, who had low alkaline phosphatases. They examined 73, and they did ALPL testing on 23 and actually found 13 patients who were ALPL positive. The symptoms: pain, back pain, myalgia, and arthritis. That's why they came to a rheumatology unit for rheumatologic manifestations. And the diagnoses in these patients before they came in were fibromyalgia, chronic back pain, unclassified myopathy, osteoarthropathy, osteoarthritis, a disease of cartilage, pseudogout, tendovaginitis, which is a term for tendon inflammation, calcific tendonitis, gonarthrosis, which is a European term for knee OA, Sjogren's, spondyloarthropathy, which is a condition, inflammatory condition of the spine, seronegative rheumatoid arthritis, which means that they were diagnosed with RA but didn't have rheumatoid factor in their blood, and then this category we call undifferentiated connective tissue disease. It's like a basket where we don't quite understand what kind of autoimmune disease they have. Those were the diagnoses that these patients were sent in with. So you can see the wide range of diagnoses, symptoms that occur in patients with HPP. There we go. So the second case is KB. She's a 70-year-old white female, and she had diffuse musculoskeletal pain since the age of 35. And she wasn't diagnosed with HPP until she had a patellar fracture, a kneecap fracture at the age of 70. She had episodic periarthritis. She had poor dentition and tooth loss. A lot of patients in my practice, they don't necessarily have premature tooth loss, defined as the loss of teeth before the age of 5, but almost all of them, or many of them, have poor lifelong dentition, poor enamel, or they lose teeth later in life. And when you ask their family history, you know, their dad lost their teeth, or their mother. And Dr. Saul mentioned about, you know, we know this is autosomal dominant or autosomal recessive. All the patients I see with adult HPP are autosomal dominant. And I have the advantage, and we all have the advantage, of having the electronic medical record. So one of the things I do in a patient like this is I say, you have daughters, you have sisters, you have a dad, you have a mother, and half of them at least are going to be in the Cleveland Clinic medical record. And I can pull their alkaline phosphatase up. All of them, almost everybody's had a CMP. And I can right there see relatives with alkaline phosphatase of 20 who are 30 years old, symptomatic or not, or maybe they have diffuse musculoskeletal pain, and they don't know why. Sometimes people who have that kind of diffuse pain just accept it, and they say, this is the way it is, and I'm going to live with it, and they don't think anything is that abnormal or something. But at the age of 70, she had the patellar fracture, and it's interesting, I mentioned this PROMIS 10 with our earlier patient, the nurse, was in like the 2nd percentile. She was the 96th percentile. She was always, even despite this musculoskeletal pain, she was a high-functioning patient. The patellar fracture actually, you know, caused some issues. See if we can get this to move. Low alkaline phosphatase, 20 in 2002 when I look back at the record, high B6. And she had osteoporosis. She had a T-score of minus 3.3. Osteoporosis is defined as a T-score less than minus 2.5. And before she was diagnosed, she was treated with Fosamax, alendronate. That's one of the worst things you can do for a patient with HPP. This is not osteoporosis. This is a disease of bone mineralization, and it's not treated by typical anti-resorptive drugs. The only drug other than Strensiq that might provide some benefit is the PTH analog family, Forteo, abaloparatide, and now generic teriparatide. And she had a pathologic variant, and Strensiq was started, and she's done quite well on Strensiq. Okay. So I only have a few minutes left. This is kind of a recapitulation of skeletal rheumatologic manifestations, much of which I've already gone over. One thing about the fractures, in addition to poorly healing metatarsal fractures, but many other fractures at many other sites, some patients have femoral shaft fractures that for all the world look like atypical femur fractures, AFF. These are fractures that we see in patients on long-term bisphosphonates, Fosamax, patients who've been on them too long. They occur on the lateral cortex of the femur below what we call the lesser trochanter. The rheumatologic manifestations we've talked about, but in my practice, this pain phenotype is much more common than almost any other manifestation now. I think in part because I'm getting referred more and more patients with HPP. Okay. This is just a slide with the difference between adolescent and adult HPP, so I'm not going to belabor this. Premature loss of teeth, one or more fractures, multiple fractures, pain, and this is the global registry, which I've already discussed. All right, so the rheumatologic manifestations of HPP presenting in adults, a wide range of clinical manifestation. Again, in my practice now, pain is a very common presenting symptom: bone pain, muscle pain, generalized pain. Many of the symptoms are nonspecific. They're varying clinical phenotypes: pain, fracture. The rheumatologic manifestations, the classic pseudogout, which is an acute flare of arthritis in the knee. I've not seen a patient with that. I've seen a lot of patients with the X-ray manifestation of that, chondrocalcinosis. The clinical course is variable and not well described. These patients are often undiagnosed for years, and in my experience, the treatment response is variable, but certainly we're super happy that we have Strinsic, and we're also hoping that we have, additional drugs. Dr. Saul mentioned some of the things that are coming down the pike, hopefully, that will treat the wide range of symptoms that we see in patients with HPP. Okay, that's it. Thank you very much.